Welcome to the Exam 3 review session. So this week you have your last exam in the course before the final. And so it will go, it's going to cover weeks 6 through 8. So a little bit on the exam before we get too far. It is worth 55 points. A lot of multiple choice, but there are many essays, like when I say essay, I mean you write in your answer type of questions. So not all just multiple choice, a lot of it you might have to write in, but the majority will be multiple choice overall. So to give you a perspective, there's actually 45 questions, but the total points is 55. So that tells you the essays have some good points assigned to them. All right, so let us go ahead. I sent out a review PowerPoint for you to follow along with. It's in your emails. So that's what we're going to kind of go through here. So let me just get this into the format I want. All right. So again, week 6 through 8. So basically, week 6 was the start of learning anemias. And then now we've learned many different types. Week 6, 7, and 8, we've learned several different types of anemias. So we're just going to go through and take away the big, broad takeaways or key takeaways from each week. Make sure you still go back, though, and look at the original lecture PowerPoints. Re-listen to the lecture recordings if you want to. Really look at those lab review questions that you guys do. Those are really important, and I think they're very helpful. I've always heard through the years students really find them helpful. So keep looking at those and studying those and doing those. And then any comments or corrections that I put on your assignments, I do so for a reason to help guide you. So always look at any corrections or comments that I may have added to any of your assignments as well. All right, so a big broad overview of week 6. We really learned these 3 anemias: iron deficiency, anemia chronic, and sideroblastic. All 3 were pretty much microcytic hypochromic anemias. So they kind of all are gathered in that category because as we've learned, we categorize our anemias according to the red blood cell indices, MCV, MCH, and MCHC. So make sure you still know how to calculate those indices, interpret those indices. I think for the most part, most of us have it down from what I've seen in discussion postings and assignments. There is a few people that here and there will glitch it, but I mean, math is math. Who doesn't glitch math every once in a while? But just make sure you understand the reference ranges and how to interpret them and calculate them. So with iron deficiency, probably the most common anemia that there is, it's due to obviously a lack of iron, and it can be for many different things. It could be there's women that need more iron as they're pregnant, growing children. If you have a chronic blood loss, you're going to lose iron, things like that. So key findings of iron deficiency that we will see in the hematology, besides the microcytic hypochromic, on the blood smear, we will see target cells, also known as podocytes, and elliptocytes. So those are 2 key poikilocyte findings. And then to confirm that it's iron deficiency, you would do iron studies. So we would see a low serum iron, a low ferritin, which ferritin again is your stored iron, but a high Cibc, that transferrin iron binding capacity. There's no iron for it to bind with. It's missing iron, so it's got a lot of room, a lot of capacity to bind. So that's a key result. I capitalize those letters for a reason, high Cibc. Anemia of chronic inflammation, or you can call it anemia of chronic disease. In this one, they have some underlying chronic disorders, such as rheumatoid arthritis or lupus, that because of the underlying disorder and all the inflammation in it, it has kind of elevated these acute phase reactant proteins. I spelled proteins wrong, huh? But anyway, these APR proteins, such as hepcidin, ferritin, and lactoferrin, which were all back on the original PowerPoint, kind of impede our iron availability. They may either bind the iron and store it and take it away for use. So we have iron still, but it's just not available. Or it might impair the absorption of the iron. Excuse me. So at some point, we have iron, but these proteins are getting involved and kind of not letting us have it for the red cells. So that's where the anemia develops. Be sure that you go back to the original PowerPoint on this in week 6 and look at the 3 actions of those. So when I say 3, we talked about hepcidin, lactoferrin, and ferritin. Make sure you understand how they are interacting with iron to result in the anemia. I do want you to know that. I didn't list it here because these are just a broad overview, but be sure to go back to that lecture PowerPoint and understand how each one is interacting with that iron. So anemia chronic inflammation is the one that will start normocytic, normochromic, and then we'll go into a microcytic hypochromic eventually as it proceeds on. I just categorized it under microhypo. I wanted you to put it there, but yes, technically it could fit in both categories, normal, or microhypo. So in this one, if you did the iron studies, it would help separate it from iron deficiency because they both have low iron, but this can have anywhere from normal to high ferritin because, again, ferritin is an acute phase reactor protein heavily involved in, in responding to inflammation. It will rise up. But the key is the low TIBC. So there's the difference of the TIBC results to help separate between them two. So really keep that in mind. And then lastly, we have Citroblastic Anemia. This can happen to a couple different things. One was lead poisoning. The other reason was any of the porphyrias, which again, I discussed porphyrias a tish, like a kind of a definition of them in the lecture PowerPoint. I had referenced that porphyrias are something we learn more about in clinical chemistry, so we don't really focus on them here. But again, a porphyria is anything involving where you're missing an enzyme or some step in the synthesis of that protoporphyrin ring. So both lead poisoning and porphyrias deal with the protoporphyrin ring not kind of getting assembled correctly, and therefore you can't put the iron inside that protoporphyrin ring. So again, we still have iron available, it's just it can't get in there, so we can't develop our red cells, which then results in anemia. So microcytic hypochromic on this one as well. Excuse me. Key finding here is those ringed sideroblasts. That is what the anemia is named for. If you were to stain the bone marrow with Prussian blue stain, so Prussian blue stain is used specifically to stain iron to show how much iron we have in our bone marrow. You would see these iron granules circling around the red cells in the bone marrow trying to get into the protoporphyrin ring but can't because, something's impeding the process of that. So that's what the hallmark sign of sideroblastic anemia. The other finding you might see on peripheral blood smear, especially in lead poisoning, is basophilic stippling, which again is made of RNA, and it kind of looks like speckles across the red cell. All right, moving into week 7, we learned about megaloblastic anemia here. There are 2 types of megaloblastic. You either have folate deficiency or vitamin B12 deficiency. There is a form of vitamin B12 deficiency also known as pernicious anemia. So all of these are types of megaloblastic anemia. It is basically whenever we can't have proper DNA synthesis is resulting in this anemia. So we need both folate and vitamin B12 to help make our DNA for cells. If we can't have them and they become deficient enough, you can't make the DNA, can't make DNA, you can't make cells. So that is what results in anemia. You'll also see all cell lines decrease because it's all cells that are affected, not just the red cells. So that is what we call pancytopenia. All 3 cell lines, the white cells, the red cells, and the platelets are decreased here because of that impaired DNA synthesis. The other thing is the name megaloblastic comes from these megaloblastic changes that happen in the bone marrow. So because our DNA synthesis is impaired, DNA is found in the nucleus of the cell. Our nucleus isn't maturing properly. The cytoplasm will keep maturing at the normal rate, at what it's supposed to do, but the nucleus is really lagging behind in maturing properly because of this impaired DNA creation. So it's what we call a nucleus to cytoplasm asynchrony. So the nucleus will lag behind, but the cytoplasm will keep moving forward and maturing. And that's what we term megaloblastic changes to the bone marrow. So that's a really key finding if we were to do a bone marrow and see that. So other features that we will see, hypersegmented neutrophils, in which you have more than 5 lobes to your neutrophils, so 6 or greater. So that's really unusual, and pretty much we only find that really megaloblastic. There might be 1 or 2 other things, but I really want you to identify it with megaloblastic especially. So that's a key finding there. If you were to ever see that in the lab, in the real world, and you saw not just 1, a couple or so, and everything else is, I would write it down. You make a note of it, hypersegmented neutrophil seen. Overall, this anemia is macrocytic, normochromic. It can be macrocytic hypochromic, but the key part is the macrocytic. The MCV is greater than 100, and it goes with the name, mega, for big. You have large red blood cells. And not only are they large, they tend to be this what we call oval macrocyte in shape. So they're large and more oval in shape to them, and that's a key finding also. We will see dacryocytes, which are teardrop-shaped cells, and then Howell-Jolly bodies. And Howell-Jolly bodies are red blood cell inclusions that are made of DNA. So it kind of all goes back to that DNA stuff. So those are all the key findings for megaloblastic anemia and how to interpret. We also discussed bone marrow stuff in week 7, both the collection process and the bone marrow failure syndromes. So when would we perform a bone marrow collection? Well, there's a few different reasons. We would perform it if we were to start seeing very immature abnormal cells show up in the peripheral smear. We would perform it if there's pancytopenia, meaning all 3 cell lines are decreased, and we cannot figure out the reason why. We've done some other testing, and they just can't get there yet, so then they can go to the bone marrow. But the basis is you never jump to the bone marrow just for anemia. We can always diagnose anemia using many other tactics like iron studies, folate and vitamin B12 levels, you know, there's a lot of other things. But if we just can't get an answer for the anemia, then we can jump to bone marrow, but we don't want to go to bone marrow just for an anemia diagnosis, because if we can diagnose it through other blood tests, we will. So ideally, on an adult, bone marrow collection is, again, in the iliac crest. It will contain core biopsy and aspirate samples. Remember, aspirate, sometimes we can't get it. We have dry tap cases. So that's when we just can't collect an aspirate, and it's either due to 2 reasons. One, there's no cells in there to collect. It's so hypocellular, there's just nothing to get out of there. Or 2, it's too many cells. It's so compact and completely full of cells you can't get them out. So those are 2 reasons you might get a dry tap aspirate. In that case, you have to get the core biopsy because you need something to look at. And again, we also learned that whole myeloid to erythroid MTE ratio. They always perform this on every bone marrow. It gives a good estimate of how the cells are being made, like what's, you know, if there's a nice healthy ratio, if there's not, if one thing's off, it can kind of indicate what cell line is getting overly produced or underproduced, if you will. A normal is anywhere from 1.5 to 1 to 3 to 1. You might even say it up to 4 to 1. That's all normal for MTE ratio. If you were to drop it down to 1 to 1, that's when your erythroid cell production is increased. I know that's hard to understand. People would think it wasn't that way, but if you think about it, we're always producing more myeloid cells to every 1 erythroid. So if we have 3 myeloid cells being made for every 1 erythroid, that's normal. If all of a sudden you have every 1 myeloid to every 1 erythroid, you've really picked up how many erythroid cells you're making that you're now being equal in the amount you're creating. If you had an increased myeloid production, then that would be 6 to 1. That number would jump really high for the myeloids. So just kind of information on that. All right, as far as the diseases go, the disorders for bone marrow, aplastic anemia basically means bone marrow failure, especially due to defective stem cells. So if your stem cells are defective, and those are the ones that make all of our cells, we're not going to be able to make our cells. So of course we will see pancytopenia with all cell lines decreased. It is a normocytic, normochromic anemia, so the cells that are made are normal in size. Most of the time we have no idea why people end up having aplastic anemia. It is idiopathic, especially when it's acquired. We have some thoughts of radiation, viruses, you know, anything out in their environment maybe they're exposed to, but otherwise we can't pinpoint it. Treatment, especially if they're under 40, is ideally get them some healthy stem cells to help get their bone marrow back into place. There were some more inherited type of disorders. All these are considered bone marrow failure syndromes. Again, bone marrow failure doesn't have to be all 3 cell lines affected. It could be just 1 cell line got affected, and that would still be considered a bone marrow failure because 1 cell line is extremely failing. So I do need you to know all these. These are the key characteristics for each one that I use to help memorize what they are. I know there were slides in the original lecture PowerPoint that covered a little bit more. You will be asked on your exam to answer these in an essay format. So if I were to give you characteristics such as this, I need you to type in the name of the bone marrow failure. So this is part of those essay questions that I said are on the test. So for Fanconi anemia, which is an inherited aplastic anemia, the characteristics here that we see with people are skin pigmentation, short stature, and hypogonadism. So if I had those as characteristics, I would want you to type in the essay box Fanconi anemia. Dyskeratosis congenita involves abnormal skin pigmentation, dystrophic nails, and oral leukoplakia. So again, the way that I use to remember this one is I remember the carat in the dyskeratosis is referring to keratin, and I remember the keratin is in our nails. So that's kind of how I remember this one. So I do need you to be able to type that one out in the essay box. Pure red cell aplasia, as the name sounds, it's only involving the red cell line, so it's a severe decrease in the erythrocyte precursors. Otherwise, the rest of the bone marrow is normal. Diamond-Blackfan is an inherited form of pure red cell aplasia. So stem cells are defective, but the cause is unknown. It is inherited, though. And then congenital dyserythropoietic anemia, as the middle name tells you. Dyserythropoietic means, again, it's involving the red cells, but it's dysfunctional development. So it's a dysfunctional red cell development, meaning you're going to get some weird changes to your red cells. So you're going to get erythroblasts that are giant, multiple nuclei, things like that. So that's always the key there. And on your exam, if you guys want to write in CDA for congenital dyserythropoietic anemia, I'd be okay with that because I know that's a long name. So if you write CDA, I will accept that for congenital dyserythropoietic anemia. Myelophystic anemia, that's always a fun word to spell. This is when you have abnormal cells coming into the bone marrow and replacing and getting rid of the normal cells. And then lastly, anemia of chronic renal insufficiency. This is where it again affects just your red cell line, and it's because we can't make erythropoietin. Our kidneys are failing, so they're not producing that hormone, and if you can't produce erythropoietin, then you can't make your red blood cells in your bone marrow. So those are your syndromes. You need to know these. You need to be able to type these names into the box when I present different characteristics in that exam to you. So be prepared for that. All right, and then week 8, we jumped into hemolytic anemias, and that's kind of where we're going to hang out for the rest of our quarter. We started with introduction to hemolysis and then also learning some intravascular hemolytic processes. Next, in week 9, we'll continue, and week 10 will continue on different hemolytics. But week 8, with the introduction, we learn the pathways for intravascular and extravascular hemolysis. I need you to know those pathways, especially that most of it's in the part of the extravascular. So I need you to be able to list in order the steps that occur in hemolysis. So go back to the lecture PowerPoint slide, re-listen to the lecture PowerPoint recording, because I went through those steps, I went through the slide once and then I listed them out at the end, I believe, again. So I need you to be able to order those. That's another essay type questions where you put them into order. I'm not trying to be secretive on what is on the test. I really want you guys to get this down. So know your steps. I'm not going to cover them in depth here because I covered them twice in that PowerPoint lecture. So re-listen to that if you need to. And then understand the differences in what is intravascular versus extravascular. So again, it's where it is occurring. Intravascular occurs within the bloodstream. Something has targeted or something inside the red cell, whatever it might be, has caused the breakdown of those red cells inside the blood. As a result, you'll get these fragmented bits of red cells called schistocytes showing up. That is the key cell finding in intravascular hemolysis. Same with keratocytes, those helmet cells kind of go with that too. The other key findings, again, is because you see this broken down red cells, that hemoglobin that was inside the red cell becomes free. It floats out into the blood, so you will get hemoglobinuria, meaning free-floating hemoglobin in your blood. Some of it will get filtered through the kidneys, resulting in hemoglobinuria, so hemoglobin in the urine, and also hemosideruria, which is that iron into the urine. Those are all very key findings of an intravascular process. Remember, we discussed haptoglobin, albumin, and hemopexin. They're involved in trying to save and bind the hemoglobin so it doesn't get filtered through the kidneys. When haptoglobin does this job and binds with it and brings it to the liver, it will not return. It gets depleted in that process. So keep in mind a low haptoglobin result is also often a finding of intravascular hemolysis. As far as extravascular, the key cell finding there is spherocytes. Spherocytes are made a couple different ways. We just had a discussion post on this. You guys did great answering it. We've also seen a case study written assignment, but there's a couple ways that spherocytes get made. As far as just normal extravascular hemolysis, there might be something on the surface of the cell that's abnormal, like an antibody or something like that, but at any rate, when the cells go through the spleen, the macrophages will identify something abnormal, bite that off, so it kind of takes a portion of that membrane. The cell will reseal itself so it has less surface area because some of the membrane's gone now, but it still has just the same amount of volume on the inside. So it makes it a very hard, rigid ball. When it tries to go through the really small splenic spaces, it is inflexible, it bursts. And that's the part of hemolysis we see. So spherocytes are always an extravascular sign because they're getting destroyed in the spleen. They're getting created in the spleen. So they're kind of being created outside of the blood. There is another way to make spherocytes that we discussed in the next chapter in week 8, which was hereditary. It was an inherited form. So we'll get to that in a second. But this is the way that is made in any of the other types of extravascular processes that there are. So I do need you to know and understand how a spherocyte gets made in the spleen. All right, so that next chapter in week 8, so here's that hereditary form of spherocytosis. This is due to a membrane skeletal protein defect. As a result, the lipids are unsupported because the skeletal proteins are defective. And so the membrane will just peel away, and then the cell again reseals itself, loses some of the membrane, but still has the volume inside, making a spherocyte. Again, it is an extravascular hemolytic disease because they get stuck in the spleen and burst. You will see reticulocytosis, and again, you always see elevated retics with any hemolytic process because your bone marrow is trying to replace the cells getting destroyed. So it's kicking out cells earlier, meaning more retics are coming out to try to replace those cells. So a high retic count is always a good sign of hemolytic conditions. For the spherocytosis, there was a test we discussed called osmotic fragility. Basically, because these spherocytes are so full on the inside, when you try to add more water to them, they burst really fast, and that's what we call osmotic fragility. And they have a high fragility. They're very fragile. They're very tending to burst compared to normal red cells. So that's a key finding. And then on your red cell indices, this is the only time we really see a high MCHC, what we term hyperchromic, even though people don't like to use that word, because of it's representing how much hemoglobin concentration is on the inside compared to the cell size. So those are key signs of hereditary spherocytosis. Hereditary eleptosis, this was also due to a membrane protein defect with spectrin. And the key finding here, we find eleptocytes in a lot of diseases, but in order to consider it this, you have to see more than 30% of your red blood cells be eleptocytes. So that's kind of how to separate it from the other diseases that have eleptocytes in them. Hereditary pyropoikilocytosis, as the name implies, lots of different shapes, lots of shapes going on. Pyro for when you heat it up, it becomes even more misshapen. So you get budding, pencil shapes, just bizarre red cell shapes in general. G6pd deficiency, this is an enzyme deficiency. Remember, we need the G6pd enzyme in the hexose monophosphate pathway. That pathway is what gives us glutathione, and glutathione still protects our red cells from oxidative injury. So you do need to keep this pathway in mind. So if you are missing that G6pd enzyme, you're not going to get glutathione to protect our red cells. So when somebody takes certain drugs or medicines, whatever, that are oxidative in nature, they will destroy the red cells, causing a hemolytic disease because there's no glutathione there to protect them. So that's where the hemolytic part comes in. It tends to be an intravascular hemolysis. The key finding here is Heinz bodies. Those are an inclusion that are made of denatured hemoglobin, or you can say precipitated hemoglobin. So you will see those little Heinz bodies. Again, remember, those can't be seen with normal bright stain. You have to use a super vital stain to see them if you suspect that they are there. But that is the key inclusion for G6pd deficiency. Proxismal nocturnal hemoglobinuria, otherwise known as PNH. This one is an acquired disorder. A lot of what we discussed in that chapter was inherited, but this was definitely acquired. There's some defect in the cell membrane that gets acquired in the red cells. As a result, complement tends to target them and destroy them. Your complement system, part of your immune system, all of a sudden sees the red cells as not being good and sets out to destroy them, and that's what results in this intravascular hemolysis. So it is definitely an intravascular process. Two tests that you can use to screen for PNH is sucrose hemolysis, otherwise known as sugar water, and the Heme, otherwise known as acid lysis. Both will be positive, telling you you have PNH. All right, so that is it. Lots of diseases in this one. So make sure you go back to those lecture PowerPoints recordings, look at corrections to your assignments, like I said, and look at your lab review questions, and you guys should be okay. So make sure you're prepared for those essay questions as well. So I kind of already let you know what to expect for essay questions. If you guys have any further questions, please feel free to email me. Otherwise, have a great week. Thank you.